material from your MSK course as well. All right, so when we cover foot and ankle, what we're going to do is we're going to cover a little bit of medical screening, a little bit of differential diagnosis. Obviously, we're going to cover a copious amount of imaging. Whatever we don't get to today, I'm going to go ahead and record. I'm actually going to record it while you guys are in MSK this afternoon. I'm going to go ahead and post it on to Canvas for you guys on YouTube, okay? So that way you guys just have it. It's there. Obviously, everything that's covered both in the in-class sessions and via a virtual format is all fair game for exams, okay? Exam is going to be very evenly split between old material and new material. It's going to be 78 questions, 3 rolling bonus questions like we always do. And it's going to be, like I said, there's not going to be one area that I harp on because I want you guys to cover all the material. And if this thing works, which is not going to work today. So when we're looking at lower leg, ankle, foot pain, obviously we got a lot of stuff down there. We got a lot of anatomy, we got a lot of physiology, we got a lot of things happening. Big areas of concern that we're going to have are going to be what we covered last week with edema. The lower I get in my body, edema is just water, it's just fluid. It's going to flow downhill. What we're going to see is we're going to see a lot of our patients are going to have a lot of swelling and a lot of edema in the lowest parts, the lowest parts of their body. So we're going to get concerned. The spidey sense is going to get turned on when we see things like decreased sensation, no matter what the cause is. We're going to get really concerned if my patient has decreased pulses, right? That should really, really concern you. If they have a fever, right? We've always talked about this semester and last semester, fever equals something really bad happening, usually infection. If they can't bear weight, that is a really difficult patient to deal with. Now, if they just sprained an ankle and they already had their diagnostic imaging done and they can't bear weight, and we know they can't bear weight, I'm not saying that we cannot treat them, but I'm saying that you just have to consider that. If there's any sort of skin breakdown, swelling, warmth, anything like that, or that red flag pain at night, we definitely want to make sure we consider that as well. So big things you can see, and this is more concentrated in the knee, but it can have implications and ramifications lower down the leg, right? If we think about it, if I have a Baker cyst, right, what's a Baker cyst? It's a popliteal cyst. What are my structures that lie in the popliteal fossa? Not everybody at once. Please tell me sciatic nerve. Okay, please tell me popliteal artery. Okay, right? So if I have a Baker cyst, I can have swelling of that popliteal bursa, which then could compress and compromise either the sciatic nerve before it splits, or the tibial nerve or the common fibular nerve individually. Obviously, that's going to present a whole myriad of signs and symptoms, such as numbness, tingling, paresthesias, distal to that infarct. Same thing if I have a Baker cyst pushing up against my blood supply, I could see something like a reduced or absent dorsal pedal pulse, right? You guys know how to take the ABI, the ankle brachial index, right? So that would be a really good case where you may have to do an ABI on a patient. Because if I have decreased pulses at the dorsal pedis pulse, then I might need to check and compare to another very available pulse. Brachial pulse is a really good one. Baker cysts can also lead to fluid distension, and there are times where a Baker cyst is not the underlying pathology. There are times when it is. I can give you an example. I had a patient who rode through Mount Zion National Park in a dune buggy, and 5-point harness, the whole shebang, and then flipped dune buggy, and then got caught in the 5-point harness by her knee, which then tore the popliteal bursa. So Lots of things happen, lots of implications. Trust me, guys, you're going to see some crazy stuff. You probably have already. So that individual just had a Baker's cyst tear. Lots of implications around that. What I can also see is that the Baker's cyst is an outlying sign of something else going on, such as a meniscus tear. So just because I see that large area of edema in the posterior knee does not mean that I don't need to do my due diligence and still do anterior drawer and posterior drawer tests, right? Still do things like Thessaly's test or an aptly grind or whatever you guys choose to do to check out your menisci. But I still need to ask myself, why is that swelling happening? Right? Remember, swelling typically is a symptom. Swelling is not typically the pathology. Right? Swelling is a sign that nothing else is going on, or something else is going on, excuse me. Acute femoral popliteal arterial occlusions. What we're going to see here is diffuse lower leg pain. Okay, we're going to see aches, burnings. This one can happen a lot. This one can happen if I have an infarct, such as I fell down and slammed my knee against the ground and it just swelled up a bunch. Right? If I have a lot of exterior swelling, then what I can have is I can have that blood supply is compromised, and it's going to show me all the signs and symptoms that I would expect when blood supply is compromised. Common causes. Again, falling down, trauma, got kicked by a mule, went 10 rounds with Mike Tyson, whatever it is, and something happened to my knee. Emboli are another big reason. A thrombus, another big reason, right? I've seen a myriad of these. I've seen folks that lacerated their popliteal arteries, and it causes some issues. This is a big one. I will say that, and this will kind of go off on a side note, rhabdomyolysis is actually more prevalent than what we think it is. It has recently gained, and I hate to say this is going to sound like the wrong word, it's gained popularity amongst certain extreme exercise groups. I won't name them or it. But rhabdomyolysis, as you can see from the bottom of the slide, the number one cause is not extreme exercise. Now, extreme exercise is up at the top of the list. Fin shrinking is the number one cause for rhabdomyolysis. Watch out for this one, okay? I have seen this happen over and over again, not just with patients that are coming in with diffuse leg pain, diffuse arm pain, whatever it is, but I've seen this in patients that were already being seen by me for another pathology or condition, such as a labral tear. Went out over the weekend, tore it up, as they say, and came in not feeling good at all, and couldn't really put their, I mean, beyond hangover symptoms, right? Like, I really don't feel well. So I had to pull this person into a room and ask him, look, tell me what's going on. I need specifics. Well, I got calf pain. I don't know why I have calf pain. I'm being seen for my shoulder. And, I went to the bathroom this morning and it was like brown. And this is something really weird. I'm like, you're right. This is something really weird. So I had to send them out. I referred them out to their primary care physician, called the primary care physician. Hey, here's what we got going on. Can you go ahead and run some blood tests on them? I didn't say, I think this person has rhabdo, because at that point I didn't know they had rhabdo, because they could have a UTI, right? They could have a whole myriad of other things. They could have had, think about all the things that would cause darkened urine, right? Everything from a UTI to another infection or pathology to a kidney stone, right? If that person has blood in their urine, that's going to cause darkened urine, it's not, right? So I called the doc and said, hey, look, this person's complaining darkened urine. They don't feel real well. Can we go ahead and get them in? Urine test, blood test, those sorts of things. Absolutely send them over. And that's exactly what happened with them, was that they had a really, really bad weekend, if you want to say it, and they gave themselves acute rhabdo because of fin shrinking. So it does happen. We've gone over deep vein thromboses a ton. Obviously, you guys have had it in other coursework as well, so I'm not going to spend a ton of time at this point on DVTs. Please use the Wells criteria. I would highly recommend, like I said, in the clinics I've worked in, clinics I managed, I had it labeled, I had it taped onto most of the clipboards in the clinic. That way it's readily accessible. I do that so I don't have to sit there and memorize it. You know, why do that? That's my opinion. If we're not aware of what the Wells criteria is, this is the Wells criteria. Watch out, especially for our postoperative patients. Remember that our postoperative patients, especially if that surgery has been done in an outpatient facility or day center, you're going to be the first line of defense. You're going to be the first provider they see after discharge from that facility. I can't tell you how many times I've seen blood clots in my post-op patients. Surgery does some weird things to people. Anesthesia does some weird things to people, right? I was told, and I still tell my post-operative patients, for the first 10 days, I have 2 goals for you. Number 1 is no blood clot. Number 2 is no infection. And then everything else is secondary, right? Because if we get an infection, what's that going to do to the rehab plan? It's going to significantly delay it. If they get a blood clot, it will significantly delay it. And I will tell you, don't get biased in thinking that only certain demographics will get blood clots. Like I said last class, if Serena Williams can get a blood clot, anybody can get a blood clot. And I give you an example. I had a patient that he was a long distance runner, the guy was a marathoner, went in for routine knee scope, right? They're going to go in, do a little meniscectomy, no big deal. Comes out, gets a blood clot within 24 hours. And what they found was that he just kind of had this underlying blood pathology and nobody really knew about. And because he was in such good physical shape, it never showed up. It didn't show up until he went through a surgical process, an extreme process to his body. And all of a sudden, this guy's on, you know, warfarin and Coumadin and things like that, and saying, I have no idea how I got a blood clot. And the answer was, I don't need it. All right, compartment syndromes. This is another really big one. Watch out, really watch out for this one. Not only in our long distance running population, also watch out for this one with our weekend warriors. You guys are going to see a lot of weekend warriors if you work an outpatient. Also, watch out for folks who have recently changed or begun a training regimen, right? What do I mean by that? Hey, I watched a running movie, I watched a running video, I'm super inspired, I'm going to go put 10 miles in. Because they feel good psychologically, we feel fantastic, and they go run. So we're going to see this a lot with folks that have recently begun a training regimen, put a lot of miles in, whatever it is. Like we covered last year in anatomy, if you guys remember that, we covered those 5 Ps. First year students actually just covered it on Wednesday. Yeah, a little nostalgic, I know, a little tear. They're growing up so fast. And remember what those 5 Ps are, okay? Pain, pallor, pulselessness, paresthesias, and paralysis. Osteomyelitis, watch out for this one. Really watch out for this one. Osteomyelitis is not going to come into your clinic and say, hey, I'm osteomyelitis. It's going to come into your clinic as a very gradual thing, right? That's going to be that patient that they get a little worse and a little worse and a little worse, and you can't figure out why they're getting worse. They're also going to have signs and symptoms of localized tenderness, warmth, right? Redness around the area. That area is going to look angry. There's going to be some swelling, and they might have an infection. Why do I say something like this? always tends to pop up, at least in my experience, when my PTAs, my techs, whomever, are beginning that patient on an exercise program, right? If you think about that, if my techs and PTAs are not aware and they're not looking for, or at least asking about things like this, or at least asking, hey, how's that ankle doing? And are there any changes? This can fall through the cracks. The last thing you really want to see as a therapist is that you reevaluate that patient 4 6 weeks later, and all of a sudden, whoa, what do you mean? Like, you look at their ankle, how long has it been like this? Oh, you know, a couple weeks. Did anyone ask you about this? No, not really. I thought it was just kind of normal. Stuff like this happens, guys. So everybody in the office needs to understand that when that patient walks in, that is a totally different patient every single time, right? That patient that walks in on their 18th, 19th, 20th visit is not the same patient. Why? Because they're 2 days older, right? They went home, they ate something, and their medical status has changed in some way, shape, or form versus the last time you saw them. They need to be treated as such. Rheumatoid arthritis is the big one. Remember the differences between osteoarthritis and rheumatoid arthritis. Rheumatoid arthritis, we're looking at symmetric bilateral symptoms. Differences between rheumatoid arthritis and osteoarthritis. Osteoarthritis is typically going to be unilateral symptoms. With rheumatoid arthritis, remember, that is a blood-based disease, okay? If they have not been checked for rheumatoid arthritis, they probably need to be referred out for a blood test to check for that specifically, because that's going to alter a lot of not only their therapy plan, but it's also going to alter things like their medication plan, because there are a lot of medications out there, as you guys know, that can effectively treat and reduce the symptoms of rheumatoid arthritis. But a lot of times these folks sometimes fall through the cracks if it has not been diagnosed, right? Because it's very easy. You know, let's say you got that patient who they're 35, 36 years old. They just took a new job at, you know, the Amazon distribution center is getting billed off at $295, and they're on their feet all day now. Well, they might have had rheumatoid arthritis all along, but never had an event that flared it up. And being on their feet flares it up. So what do? They go to the doc. Hey, both my feet hurt. What's the diagnosis that they're going to get? Plantar fasciitis, right? Foot pain, plantar fasciitis. Well, they might not have plantar fasciitis. They may have something like rheumatoid arthritis. But we need to be savvy enough and thorough enough with our examination that we can identify that and make the appropriate referrals. To confirm rheumatoid arthritis, you have to have 4 of the 7 signs. Okay, so a lot of these we're going to ask. Okay, do you have morning stiffness that lasts longer than an hour? I will tell you that that is one of the key pieces of information that differentiates osteoarthritis and rheumatoid arthritis. Remember also ankylosing spondylitis, right? Pain the second half of the night, gets better after I get up and move around a little bit. Osteoarthritis, pain when I first wake up, gets better after I move around a little bit. Do you have arthritis in more than 3 joints? That's a big one, right? If I have arthritis in a whole bunch of joints, I at least need to screen for rheumatoid arthritis. I'm not saying you definitely have it, but we need to screen for it. Again, symmetric symptoms, anything symmetric, anything bilateral, we need to automatically think systemic, not localized. You may see folks with rheumatoid nodules, right? In advanced cases, you will see deformities to the hands, deformities to the feet. And I'll be quite honest with you, the x-rays look sometimes pretty gruesome. They will have a positive serum rheumatoid factor. And like I said, they're going to have some X-ray changes. Other things to watch out for. We are going to see patients with abscesses. We're going to see patients with especially plantar abscesses. We need to check these patients. I'm going to highly recommend, now obviously we should be doing skin inspection for every single patient that we see, but I'm going to highly recommend if someone comes in that's either diabetic or pre-diabetic, the shoes better come off and you better check the skin. Also, probably they need to be periodically checked to make sure, because they're not going to feel it obviously, especially if they have neuropathy. Is there swelling? Is there warmth? Right? Does that foot look angry? If that foot looks angry, chances are it is angry. And chances are there's going to be some other systemic signs, like fever, chills, things like that. Typically, we're going to see abscesses that are going to happen in the main weight-bearing sections, right? So central plantar region, if that person has pes planus, we'll obviously see it more than someone with pes cavus. Why? Because pes cavus, that medial longitudinal arch typically is not going to contact the floor. But a lot of times you'll see it around the met heads. A lot of times you'll see it around the heel. Why? Because those are going to be my main weight-bearing contact surfaces. We're going to get this person in for an MRI. And the reason we're going to go straight to MRI is because we're going to be able to see a large bone and skin reaction that's happening in the soft tissue. X-ray is not going to show much on this. Why? Because it's mainly a soft tissue injury. Avascular necrosis. This can happen a lot. Watch out for this one. This is another one that is not going to pop up acutely. This one's going to happen over time. Remember that patient that had maybe a foot fracture, and let's say it's the 1st of April, they may not show symptoms until the 11th, 12th, 13th, 14th, 15th of April, right? About that time, that patient is not being seen by the PT, being seen by a PTA or another individual, and maybe that person thinks this is normal. Maybe it's supposed to hurt, right? There's a lot of folks out there that just have this idea that therapy is supposed to hurt. Well, there's a difference between pain and soreness, obviously. Our individuals with severe pes planus are going to be more at risk for avascular necrosis. So that's something just to watch out for as well. Probably what we should be doing, if the patient is appropriate, is we should be assessing their foot posture, right? Are they pes cavus? Are they pes planus? Do they have a flexible foot? Do they have a rigid foot? You guys will go over that if you haven't already in MSK. Sever's disease can happen. I've had a couple patients in my career with Sever's disease. This typically is going to happen around a large period of growth. Remember, the number 2 time that somebody grows in the life cycle of a human is in adolescence. Funky things happen in adolescence. So if my patient comes in, especially with bilateral heel pain, and they are 12, 13 years old, I'm asking them, or I'm asking a parent, how much have they grown recently? And usually you'll get the answer, oh man, yeah, they've grown 5, 6, 7 inches. Right, like I said, it's crazy. For those of you who have siblings, cousins, whomever, who are in that age group, my son is person in the age group. He's gone from 5'4" to my height in the school year. So it's crazy. But symptoms are going to remain very consistent. Okay, I'm going to have heel pain. Might be on the medial side, might be on the lateral side, might be directly posterior. It's going to hurt when I palpate. I'm going to have edema, warmth. It's going to hurt worse when I'm bearing weight, and it's going to be less when I'm resting. It's very common in young athletes. Remember that in a lot of cases, athletes start specializing right about the time of adolescence. Okay? That's when we see a lot of athletes that will start specializing in one sport, or they will play on multiple teams, or they will introduce strength and conditioning programs, right? So we can see this a lot in that age range because that is a very big period of growth and they have some extra demands placed on them. Watch out for stress fractures. Stress fractures of the calcaneus happen a lot actually, and it gets commonly misdiagnosed or underdiagnosed, I should say. Same thing. Okay, a lot of those same signs and symptoms. Pain, edema, redness, swelling, all that great stuff. Hurts worse when I put weight on it, hurts less when I don't. One thing we need to watch out for, and one thing you really need to ask your patients, and this is really where I think doing a very thorough occupational demands history on your patient is important. Don't just ask them what they do for a living, but they need to go through what their occupational tasks are. Okay, I'll give you an example. So in my hometown, there's still a lot of walking mail routes. They walk on concrete for the majority of the time. Concrete has less give, less force dispersion than asphalt does. So I used to see a high amount of mail carriers in my clinic because they would walk these routes. And sometimes if they're walking a bunch, they'll walk a few miles, right? Up and down stairs, in and out of apartment buildings, whatever it is. So ask what those occupational demands are. The test we're going to do for this is going to be the squeeze test. Super simple, super easy, says what it is what it says. Squeeze the calcaneus. Now I'm not saying like put it in a death grip, right? But just kind of give it a little squeeze. Trust me, when I say this, if they have a stress fracture, they will let you know. My recommendation is take one step back when you do it, because you might get donkey kicked. It can hurt. All right, let's go ahead and let's take 5 minutes and do a little DVT prevention.
counts today?
I'm sorry. Yes. Yeah. All right, guys, let's get rolling again. All right, so when we look at heel pain, and especially entrapment of the tibial nerve, watch out. Watch out for this one again. Tarsal tunnel syndrome is a real thing. It can happen a lot. It can creep up on you. Okay, so let's think about this. Let's think about the patient that comes in. They have an eversion sprain, right? So what ligament are they going to rupture if they have an eversion sprain? Please tell me deltoid ligament. Okay, so deltoid ligament, what's going to ride just posterior to that little deltoid ligament? Tarsal tunnel, the Tom, Dick, and Harry muscles, right? Posterior tibial artery, tibial nerve. So I could have a rupture of that ligament, partially or completely, and then I have a bunch of swelling. That swelling then starts pushing on tibial nerve or posterior tibial artery, and I can have some serious problems. So watch out for this. Also, I can have a lot of issues with things like RA, rheumatoid arthritis, and gout. It can come from the S1, S2 nerve roots, right around that SI joint. Just watch out for these things simply because there's going to be a lot of different things. Like I said, everything's going to come in. It's going to say ankle pain, foot pain, plantar fasciitis. It could be a whole host of other things. You know, like I mentioned to you guys earlier, this might have been last year or this year, had a patient come in with a script that said peroneal strain. It was foot drop because she had a ruptured L4, L5 disc. But went in, saw PCP, and PCP's like, well, I think it might be your peroneals. And it wasn't. It was, she needed a neurosurgeon. This is straight out of JOSPT. Watch out. I would highly recommend, just as a broad clinical note, the CPGs that have been put out by the APTA are phenomenal. They did not exist when I came out of PT school, and they have been a really good resource. When we're looking at heel pain, plantar fasciitis, take note to a lot of these key special tests. These things will save you a lot of time, a lot of headache, a lot of guesswork. And that's one of the really nice things that in progression of physical therapy services and as a science we've really done in the last 30 years is we are making the job much more objective, as opposed to, yeah, I think it's this, or yeah, I think it's that. Gout is a weird one. Watch out for gout. Gout's going to come into your clinic and it's not going to say gout. It's going to say foot pain or plantar fasciitis. We need to watch out for it because it's going to have a lot of the signs and symptoms that are most associated with something like an infection, except for the fact that it can only happen unilaterally sometimes. Okay, and this is where it gets a little tricky. What we've talked about up to this point is that if I'm systemic, there's a very good chance that I have bilateral symptoms. This is one of those strange cases where I could have unilateral symptoms and I can still have a systemic condition. Typically where we're going to see this, first MTP joint, that's the most typical one. It can happen around the talocrural joint, calcaneus, or midfoot. Males are 8 times more likely to be affected by this than females. And this is where you may have to ask some food and nutrition questions, because there is a pretty positive correlation between gout and the consumption of animal products, aka meat. So watch out for this, right? So you may see somebody, let's think about this. They come in, hey, got in the Facebook group, gonna get ripped, gonna get swole, whatever it is. And I'm on this diet where I'm consuming 7,000 calories a day of chicken. You guys can see, it sounds ridiculous, but you guys can see this happening, right? Or I am consuming nothing but protein powder, right? Where's protein powder come from? Where's whey come from? What is whey? What's that? Milk protein, right? Who knows the little saying, Little Miss Muffet? Little Miss Muffet sat in her tuffet eating her curds and whey. Whey's the stuff they scrape off the top of the milk before they stick it in the jug. And then they powderize it, and you guys spend $19.99 per jug. So we need to watch out for these things, right? So if I have a high animal consumption, meat, protein powder, whatever it is, I may have some signs and symptoms of gout. These folks will need to go get a urine test because they're going to have large deposits of monosodium urate crystals in their urine. Now, gout's very easily treated, but it's going to be treated by medication because we need to get those crystals under control. A Lisfranc or Lisfranc injury is a very common injury that we're going to see. We're going to see this both with our athletic population and our non-athletic population. This one can get a little tricky because this is going to be that patient that comes into your clinic and they're just going to complain of this kind of weird mid-foot pain that doesn't make a lot of sense. Right? And just they don't know really how they got hurt sometimes. Sometimes they do. But what they're going to have is, and I mean, look at the list of symptoms here. Can be reproduced with active supination, pronation, weight bearing. There's pain, there's tenderness, and edema. And you're going to throw your hands up, wow, what this is. And a lot of times it can be a Lisfranc injury. Both, like I said, most commonly associated with our athletic population, but I've seen plenty of non-athletic traumas as well. So looking at the mechanism of a Lisfranc injury, typically what we're going to see is we're going to see the Lisfranc ligament, which is just a ligament between the second metatarsal, first metatarsal, and cuneiforms. This gets torn. Now the picture I want you to pay attention to is the picture on the left-hand side of the screen. What does that picture look like? That picture looks like I'm landing on my toes. Right, so you can definitely see where this could be an athletic injury, right? If we have an individual that's playing basketball on a hard surface or a tennis player playing on hard court, and they hit that MTP joint, and now they have midfoot pain, there's a possibility they're going to have a Lisfranc injury. What other population has their foot in that position for a prolonged period of time? What's that? Ballet. What other population? Non-athletic population. Those who wear stilettos, right? High heels. Think about that, right? That's exactly the position you're going to be in if you wear high heels. Now, here's how it works. Going out, got a nice dinner happening. You got the 4-inch stilettos on. Get picked up in one of those trucks that has like the 18-inch lift kit to it. You know, you have to like get catapulted into the truck, that sort of thing. And now you got to get out of it. So what do? You jump out. And what are you wearing? The stilettos. What are stilettos not designed to do? Really, the answer is nothing, right? They're not designed to do anything except cause foot pain. But you can see how this happens. Now I have this mid-foot pain. Oh, I'm not sure really how I got hurt. And we can kind of track it back to something like jumping out of a car or even getting out of a car or truck and having this ligament injury. So watch out for these things. Now, MSK conditions that we can specifically say, yeah, your overpronation is probably causing this. Plantar fasciitis is one of those. Like I've mentioned in the past, plantar fasciitis is one of the more overdiagnosed medical diagnoses out there. Morton's neuroma is a big one. I've had some patients with Morton's neuroma and that they actually will go get it fixed. They'll take out the cyst on the nerve. Stress fractures are a big one. We're going to see this especially in our populations that are walking, running, jumping, doing a bunch of activity. And then things like tarsal tunnel syndrome. There's actually a little bit of information, a little bit of research behind overpronation and its correlation or connection with patellofemoral pain syndrome. Now, somebody that underpronates, aka oversupinates, we could see some lateral ankle sprain and chronic instability. That person is going to have more risk to have stress fractures or shin splints simply because they are not dispersing the force when they hit the ground through their foot like they should. So what happens is that force then just kind of rides up the chain and ends up getting absorbed a lot of times in the tibias. Very often it's going to get absorbed in the knees as well. And then what we could see is we could see some lumbosacral pathologies. What I will tell you is, and I understand this class is all about all the weird things that can happen to a human body. There are times when it's just a lumbosacral pathology. Don't make it more than what it is until it's something more than what it is, okay? I went through that period where I took this course 10 years after I got my PT license. All of a sudden, while I'm in the course, everything was wrong with everybody. Holy cow. I was diagnosing all this stuff, and I thought it was great. I was wrong like 99% of the time. So it's simply because an ankle sprain, sometimes just an ankle sprain, right? Not every ankle sprain is gout. Not every ankle sprain is cancer. So just recognize that. You know, like I said at the very beginning of last semester, put your bet where the numbers are the best, right? If you have a 95% chance that it's patellofemoral pain syndrome, go with that, because only 5% of the time it's going to be something else. So we've got two different patients here comparing tarsal tunnel versus plantar fasciitis. Patient one, low on the overweight side, stands a lot of work. They're complaining of foot pain when she first steps down in the morning, improves a little bit after walking a little bit. More painful every other day during the week, but it's better on the weekends. Okay, now that's a huge pattern, right? I know you guys go over an MSK going over that 24-hour pain cycle. I'm going to recommend that you expand it farther than that, because here's what you will see sometimes. I feel okay on Monday, but by Friday I can barely move. And then I rest all weekend and I feel okay on Monday again. Okay, so that's a pattern, is it not? So what we need to figure out is what's happening from Monday to Friday. We check out this person, ankle range of motion, fantastic. Actively and passively. Strength testing, fantastic. They have a little bit of tenderness over their anterior calcaneus. EMG, NCD look okay. The other patient reports spraining ankle 2 weeks ago, thinks he's turned his foot outward, right? So that's going to be a knee version sprain. Burning in the sole of the foot, worse after walking 5 or 6 blocks. Sometimes it wakes him up at night. Excuse me. Ankle range of motion, passively and actively look okay. Some pain at the end of the range of pronation. Strength testing looks okay, no pain with that. Palpation, a little tender posterior to the medial malleolus. And EMG testing looks not so great. So prolonged sensory and motor latencies, we're going to get into that in the very last section, what that means. Excuse me. North Carolina Aprils are killing me these days. So what that means is that if there's a prolonged sensory and motor latency, essentially what that means, it takes longer for the signal to get from point A to point B, right? That's what a latency is. So what that is indicative of is that there is some sort of nerve injury. And we're going to get into that in the very last section, like I said. So these patients are very, very different. Very different in terms of pathology, very different in terms of presentation. The big one is that EMG NCV, right? If I do an EMG on a patient and nerve looks fine, everything looks okay, we can probably rule out or screen out something like tarsal tunnel syndrome. If that EMG NCV does not look okay, then we need to at least consider that's a possible source of the pain. And like I said, we'll get into that in the very last section. Rheumatoid arthritis. 16% of the patients out there are going to have something happening in terms of rheumatoid arthritis. Now, that means 84% don't, right? But we need to at least consider it. Again, think about all the evals you're going to see. Average PT sees how many evals a day? How many evals would PT see in your clinics? 4, 5, right? Multiply that by 5, that means 25 a week, right? How many weeks does the average PT work a year? 50, right? You typically take 2 weeks of vacation, and there's 50 weeks, there's 52 weeks in a year. All right, so think about, if you just extrapolate the numbers out, how many evaluations that person is going to see that year. That's a lot. Now, they're probably not all going to be foot and ankle, obviously, but you're still going to be really well represented depending on the clinic that you're in. We're going to see some synovitis of the metatarsal phalangeal joints. There might be some synovitis of talar-navicular joint and subtalar joint. Again, overpronation is common, not all the time, but we're going to see symmetric bilateral symptoms. Okay, that's a big key, is symmetric bilateral symptoms. There's a lot of named fractures. We're going to get into this when we get into more of the imaging section. We're going to talk about pylon fractures and boot top fractures and trimalleolar fractures and bimalleolar fractures and all these great fractures that everyone likes to stick their name on. Jones fracture is another one. So there's a lot of eponyms in this. We will go over what these mean simply because you will see this terminology on radiologist reports. You will see Jones fracture on a radiologist report, I can almost guarantee it. So you need to understand what these mean. All right, so it gets into radiology. Foot and ankle, very, very common. Most of them are soft tissue. Understand that. Understand that we're going to have a lot of patients that come in and they have already had their series of radiographs done before they hit our clinic. Understand that the majority of those films are going to come back either inconclusive or negative. It is really going to be up to us to monitor and evaluate those patients thoroughly because these slip through the cracks all the time. We're going to have a whole other set of Ottawa ankle rules in addition to all the other Pittsburgh and Ottawa and Canadian rules we've had. And there's a wide range of specificity reported with those rules. Okay, that's really important to remember because just because my patient falls into that Ottawa category or does not fall in the Ottawa category does not mean I have pathology. But the Ottawa rules can be useful when I'm ruling out a very significant fracture. This is straight out of Riemann's textbook that you guys use with MSK. Notice the pattern here. Okay, so my gold standard for a lot of this stuff is surgery. As I said many times in the past, there's no substitute for getting in there and looking with your own eyes or with a camera. Understand that the diagnostic test of choice for a lot of these pathologies is going to be MRI because, like I said, majority of foot and ankle injuries are going to be soft tissue, so it makes sense. Also understand the use of ultrasound for both of these. So this is where we can make a significant impact, and what I would really like to see happen in our profession is that diagnostic ultrasound becomes normalized, that we start using it more. Bless you. I think we have a ways to go. I think we need some better training, we need some better tools, and I think we need more clinicians using it. But things like an Achilles tendon tear, look at the numbers, right? 94% sensitivity, 100% specificity. That's pretty darn good. So I think ultrasound can be widely used, and I think a lot more used. All right, let's get up again. Take another 5. Okay, you guys are already falling asleep. He did not. It's okay. It's okay. No. Well, no. I've done it.
Yeah.
Right. So you guys, exactly. I've done it. In the past. Back when the others was nice. Now the direction is that. So. That because that was my responsibility. Absolutely. That's one thing on. Do I look damaged? Exactly. What's up?
Would you still have some pain moving through the strength testing and range of motion with the plantar fasciitis?
Sometimes yes and sometimes no.
Okay.
Remember, plantar fasciitis is the most non-productive.
Yeah. So if it's not really aggravating anything, it's not.
Now, what you have to think about is how am I positioning the foot with all those things, right? So if I am peeling the toes back into extension, what am I doing with plantar apnerosis? Stretching it. Exactly, putting on tension. So that's made a risk response. Or if I put my patient and I want them to press into my hand for plantar flexion, I put the dorsiflexion, same thing. Right? So you kind of have to consider all those things.
The main thing would just be like the EMG.
EMG's going to be the big one. That's going to be a confirmatory test. We're going to go over that, like I said, the very last section. I'm just going to warn you. It's actually, it's already on YouTube. So I'm going to do it live. It is. Yeah, you're in TV. Everyone's going to look good. I don't know what's going on. Because literally it's all based on sound. And it just, ask Allie about it. Because Allie was the last class. And they did a month of EMG. Yeah, that's they really shocked me for a month. It was. They did. They did an EMG study for a month. So yeah, so when I first taught this course in 2019, at this time of the semester, I was so done. He was saying, Dr. Fleming would come in and do a month of EMG stuff with him. Yeah. And I'm sure I haven't seen a lot of short. All right. Yeah, that'll work. Well, you know. It's weird. All right, guys, let's go ahead and get rolling again. So we talked about audible rules for a couple different body parts. At the ankle, the big things we're going to see at the foot and the ankle is that if I have pain surrounding one or both malleoli, then that's going to be one of those positive signs for the audible ankle rules. If I have tenderness at the posterior aspect or tip of the lateral malleolus, or tenderness at the medial malleolus, or inability to bear weight, both immediately and in the emergency department, then obviously we need to get that person in for some radiographs. When you follow the audible foot and ankle rules, 100% sensitivity, really, really super nice. Specificity, not so nice. But as a screening tool, which is what a lot of these rules are, it works out really well. For the foot, if I have pain around the midfoot and tenderness around the fifth metatarsal base, tenderness around the navicular, and again, that inability to bear weight, both immediately and in the ED, we need to get that person in for x-rays. So typically, and this is basically just a visual of that audible ankle rule. There's 3 different zones. There is the malleolar zone, the midfoot zone, and then what the picture's not showing is the forefoot zone. So my malleolar zone and my midfoot zone are really going to be key with a lot of these radiographs, because as we think about it, that's where I'm going to bear a lot of the weight with a lot of my traumas, right? People land on their heels, land on the midfoot, and there's obviously a lot of moving parts just in that area. Like I said, that's just another visualization of that same concept. So again, very sensitive. If there's a fracture present and our audible rules are positive, it is very, very sensitive. It's not terribly specific. And the information, the literature out there says anywhere from like 40 or 45% to 70 or 75%. So what does that mean? Just because my patient does not have the audible rules popping out and positive, and just because they show nothing on an x-ray or radiograph, does not mean that they have nothing going on, okay? Again, these things pop up all the time. I can't tell you how many times I've had patients, because think about the amount of edema, like I said at the very beginning, that can happen in the foot and the ankle. I can't tell you how many times I've had patients come in, they're not sure if it's fractured or not, and 7 to 10 days later, swelling goes down, it still really, really hurts, and then the fracture shows up after all the swelling has reduced. So that is a very typical presentation as well. This is straight out of the ACR criteria. You guys remember that from last semester? Again, if I have an adult or a child over 5 years, I'm going to use those audible ankle rules. Okay, so just be aware of those. Again, if I'm not able to walk on it, probably should get some x-rays done. Now, these are the ACR criteria relative radiation levels for all of these different imaging modalities. This is nothing new. This should be relatively old information. It kind of tells us what we already know. If I order an x-ray for my patient, I'm going to produce and expose them to a little bit of radiation. If I get them in for a bone scan, they're going to get a whole bunch of radiation. As we can see, CT scan in terms of relative radiation level is not much higher than my x-ray. But the thing we need to watch out for is look on the left-hand side of the chart, and a lot of those images usually not appropriate. Why? Because they're not going to show you a whole bunch. Now, with other variants, with other material, with other information, those can be more appropriate. These are the main views we're going to see with the lower leg and the ankle. There's going to be a couple that are just a little different versus what we've seen in the past. Obviously, we've seen APs. We've seen a bunch of APs. We've seen a bunch of laterals. The mortise view is just going to be a little different view. It's going to place the foot and the ankle in just a little different position. And what it's going to do is it's going to give us a nice view of the mortise joint. This is the position that the person is going to be in for an AP leg projection. The patient's going to be supine. Femoral condyles are going to lay parallel to the table. In other words, I'm not in any external or internal rotation. And the foot's going to be vertical, aka a neutral dorsiflexion, plantar flexion. This is typically what we're going to see with an AP leg projection. Now, please note, I can see two different tibiofibular joints here. Right? I can see a proximal one, and I can see a distal one. Note that, because this is a key piece of information. Why? Because if my patient has lower leg pain, maybe they have a stress fracture, maybe they just have pain, maybe they have a trauma, whatever it is, I can get both of those tibiofibular joints viewed by exposing my patient to one shot of radiation. Okay, that's really important. Obviously, we want to expose our patients to the least amount of radiation possible. So if I can view both of those structures in one shot, I'm a lot better off. This is typically how the lateral projection is going to be taken. Now notice what you see here. The lateral projection, even though it's called lateral projection, is going to be shot from medial to lateral. Okay? So my medial structures are going to appear, quote, on top of my lateral structures. That's going to be another key piece of information, because what I want you to think about, I'm going to slide back one slide here. The lateral malleolus, if you remember from anatomy, sits a little more distal than the medial malleolus. Okay? Now, that's going to become important because we're going to see this little tip of bone come out for the for the lateral projection of the ankle, and that's going to be a normal finding because it's going to be the lateral malleolus. It's not going to be something abnormal. Don't think it's a chipped bone. This is typically what the lateral view is going to look like. Now, the other key piece of information with the lateral projection is that my fibula is going to sit, it's going to look like it sits just a little bit posterior. That's just how it's going to look. What we're going to see, though, like the second point on the slide says, my proximal and distal tibia and fibulas are going to be superimposed. They're going to sit right on top of one another. Okay? Now, where does this become important? things like final exam questions. Hey, you have a patient with blah, blah, blah injury, and you want the radiographic view that's going to show the proximal tibiofibular joint the best. I guarantee one of the choices or distractors is going to be lateral. Do not choose it. Okay? So that's where this is going to become important. This is an AP view of the ankle. Same position as AP view of the leg, but my radiation and my beam is going to be shot, obviously, essentially straight through the talus, or straight through that mortise joint. This is typically, and obviously this is a drawing or artistic representation of what an AP view is going to look like. What can I best see here? Distal tibia, distal fibula, proximal talus, talar dome, ankle mortise, things like that. Again, that patient comes in, they have ankle pain, you suspect a talar fracture. Which view is going to be best? Don't say AP leg. Why? Because I'm not going to get a really good view of the talar dome here, am I? This is typically what an AP ankle is going to look like. We can see a lot of different stuff here. We can get a lot of good information. Not only can I see the distal third of the fibula and tibia here, I also can see my medial and lateral malleoli, and I can really see that tibio-talar joint well. So we're going to go over little things like the spacing between the tibia and the fibula. We're going to go over, if you guys remember from anatomy, those syndesmotic joints that when the ligaments get ruptured can be indicative of a high ankle sprain. This is what lateral projection looks like. So my patient's going to be side lying again, or at least their leg's going to be side lying, and that beam is being shot from medial to lateral. Again, drawing representation of what I'm going to see. Now, the thing you have to watch out for is that I'm going to have a lot of superimposition here, right? I have a lot of structures laying on top of other structures. Going back to basic radiographic rules, that's going to lead to a lot of obscurity. Plus, it's going to lead to a lot of increased radio density and radio absorption, right? Those structures are going to appear a little brighter because I'm having more beam getting absorbed. This is the mortise view. Now this one's important because there's one subtle difference between an AP ankle and a mortise view. And the subtle difference is that the entire leg is internally rotated about 15 to 20 degrees. And it's one of those very subtle differences like we saw in the knee with a sunrise view versus a tunnel view. The patient will have to maintain the dorsiflexion on their own with this one, and sometimes that can be difficult. What this essentially does is it places the intermalleolar plane parallel to the table. What we're going to be able to see is we can see a lot of the same stuff that we're going to see with the true ankle AP, but we're going to be able to see that interface between the distal tibia and the talar dome a lot easier. We're not going to have that superimposition or just that little bit of rotation or skewing. So as you guys can see, a lot clearer representation at the distal tibia and fibula. I can really see that mortise joint well. That's why it's called the mortise view. What I'll tell you is that the mortise view is good for viewing a lot of different structures. Obviously, if I have a lateral malleolus fracture, I'm going to be able to see that. However, if I want to view the mortise joint, I want to use a mortise view. Okay? Pretty simple. This is how an AP foot looks. Okay, so what happens is that my patient's knee is placed in usually 90 to 110 degrees of flexion, if they're able. And they need to be in enough flexion to place the foot flat on the table. The beam's going to be shot down straight through the top of the foot. Usually there's a tiny, tiny bit of a posterior tilt, usually about 10 degrees. And that's just to reduce the amount of superimposition that can happen at the foot. So obviously, remember, we have a lot of bones, things like the cuboid, things like your navicular, that all have these little hooks and tunnels and grooves in them. This is how an AP foot looks. Now, big things to note here. On the plantar surface of the first metatarsal, there are two sesamoid bones. If you guys remember from anatomy, the flexor hallucis longus tendon and flexor hallucis brevis dive into and encase those two sesamoid bones. You know, clinical tip, if you have that patient that just can't get full first or great toe extension, take a look at the sesamoid bones. And a lot of times they're involved. Also note that at the metatarsal bases, in the AP view, I'm going to have a little bit of overlap. There's going to be a tiny bit of overlap at metatarsals 2, 3, 4, and 5. This is why fractures get missed so often. Let's think about this. Had a patient about 15 years ago, opens up her freezer. You guys ever seen those big frozen cans of orange juice? I'm not talking like the little one, I'm talking like the family size, like the big ones. It falls out of the freezer. It falls directly onto her bare foot, striking the base of metatarsal 3. X-rays came back inconclusive. X-rays came back inconclusive because of this overlapping. Okay, so yes, that's kind of an extreme example. No, I've only seen one of those in my career, but it can happen. So moral of the story is, just because the X-ray says it's conclusive or negative does not mean we don't have a fracture. This is typically what we're going to be able to see with my foot AP view. Obviously, I can see all my phalanges and the IP joints, metatarsals, those sesamoid bones, tarsals, the Chopart joint and Lisfranc joint. Okay, you guys are probably going to go over those in MSK, but I'll kind of cover them here as well. Essentially, what the Chopart joint is this transverse tarsal joint. Okay, so this Chopart joint is right in here. Okay, that's your Chopart joint. These are really important because it's a big midfoot transition between a couple really large bones that don't like to move and like to slam into other bones, aka my calcaneus and talus, to my more flexible bones that move all over the place, like my navicular and my cuboid and cuneiforms and things like that. The Lisfranc joint is the tarso-metatarsal joint. So that's this guy here. Tarso-metatarsal joint says what it is what it says, right? It is the joint in between my tarsals and my metatarsals. Obviously, another big source of transition between my midfoot and my forefoot. You guys have seen this over and over and over again. Anytime I have a big transition from one body part to another, one type of tissue to another, that could all be sources of stress, all be sources of injury as well. This is the oblique foot projection. Essentially what's going to happen here is the patient's going to lay supine. Obviously, they're going to bend their knee to, let's call it about 90 degrees. Again, it's going to be enough knee flexion that the patient can rest their foot flat on the table. The big difference here is that with the oblique view, I'm going to post up that foot so it's about in 30 degrees of internal rotation. And that's going to be very important because I'm going to get a totally different view just from that little difference of rotating 30 degrees. This is what an oblique view looks like. So with this patient that the orange juice container fell out of the freezer, that's what we end up having to do is send her back in for another series of x-rays. The oblique view was used with this patient, and what we found was that there was a little fracture right here. It was, I'm not saying overlooked, but it was obscured by the AP foot view. The oblique view definitely showed it though. So again, this is what an oblique view is going to look like. What am I best going to see here? The metatarsal basis of digits 3, 4, and 5, no superimposition. There is a tiny bit of superimposition between 1 and 2 and 2 and 3. So if I need to see my metatarsal basis, and if I need to see my lateral tarsals, I need to order at least an oblique view. Obviously, what we talked about time and time again, one view is no view. This is how the foot lateral projection is going to look. Again, foot's going to be placed in neutral plantar flexion and dorsiflexion. The beam is going to be shot from medial to lateral, and the entire lateral surface of the foot is going to be in contact with the table. This is what the lateral view is going to look like. This is going to be really key and really important for viewing things like the calcaneus. Right? It's going to be very key and very important for viewing and giving myself another perspective of that Chopart joint and Lisfranc joint. This is what a lateral view is going to look like. Now, obviously, with this individual, they have some big time curling of their toes or flexing of digits 2, 3, 4, and 5, as you can see on the bottom part of the screen. But as you can get a good appreciation for, I can see navicular pretty clearly here. I can see cuneiforms, or at least the medial cuneiform, pretty clearly. I can see calcaneus pretty clearly. All right, I'll tell you what, guys, let's go ahead and let's cut it there for the day. Like I said, I'm going to record the rest of this, and everybody have a very good day.